welcome everybody. It's great to see everybody here. We've got a good team here. I think more than 100 people, 150 people or something like that, and you're all very welcome. The RSM's had a bit of a struggle over the last couple of years because of COVID. You know, this lecture theatre hasn't been used in the way that we used to use it, so it's so lovely to have you all back again. So this evening we're talking about what I think is the most important subject in the entire universe. But I would say that, wouldn't I? Because I spent my life looking after patients with prostate problems. So we're talking about prostate cancer, and we're so lucky to have, I think, the leading urologist in the UK. Some people would say one of the best urologists in the world, I think. Mark has done such great innovative work, and he'll be telling you all about that. So I'm also really, really pleased that the Howard Foundation, John and Julie, who are going to just talk to you in just a few minutes, are going to tell you a little bit about Alan Howard and his amazing Cambridge diet, very famous diet. Helped me lose a bit of weight, actually, that Cambridge diet. It really worked. Great stuff. So they have sponsored this evening, which is why we're able to let you come in here free rather than charging you £250 each. So you should be so grateful to these two. So I think without further ado, they're mic'd up, and are you both going to come up at the same time and talk? So Alan Howard and Julie are going to tell you. John, so not Alan.
I may
John.
look like my father, but there we go.
John and Julie, over the years.
Yeah. So just to clarify, I'm John, and my father was Alan Howard, and he was the founder of the Howard Foundation Charitable Trust. Almost 40 years ago to this day. He was a Cambridge University nutritionist. I was his son, then a practicing solicitor up in Leeds. And he was actually inspired by Henry Wellcome's original concept for the Wellcome Foundation, in the news only today, of the idea of a virtuous cycle whereby companies in the pharmaceutical, in our case nutraceutical sector, invested in ongoing research to create yet a healthier society. Back in 1982, Alan Howard knew that his invention of what was then a patented formula of a very low-calorie diet and to be marketed as the Cambridge diet was taking America by storm, and he was hoping there would be generous royalties forthcoming. And in the end, he himself oversaw the creation of a UK company, and it marketed the slimming products, as mentioned by Roger, as a nutraceutical available from successful users who themselves became counsellors. And the company spread worldwide, and its descendant organisation is now employee-owned with 300-strong workforce and a trust based on the John Lewis model. And dare I say it, millions have lost weight and become healthier worldwide over the last 40 years. Alan and myself were both alumni of Downing College, Cambridge, one of the poorer Oxbridge colleges, but it did offer places to grammar school boys like Alan Howard, who grew up during the war in a working class background in Norwich. Alan knew he owed everything to the university, and he wanted to put something back to his college. And in 1984, the foundation made its first £1 million donation for a public building there, followed by a residential building in 1994, and a glorious classically inspired theatre in 2007. And this was made possible by the sale of his beloved diet company to its management. He lived a further 10 years after the theatre's opening to enjoy public and student productions before his death from prostate cancer 2 years ago.
John and I have very personal reasons for supporting this important event tonight. In 1980, we lost our grandfather, Alan's father, to prostate cancer in the days when understanding and treatment of this illness was limited. Then in 2012, after several years of specialist treatment, Alan's younger brother, our Uncle Roger, also died of the same illness, aged 73. Alan himself was diagnosed with early-stage prostate cancer in his 70s. But being a scientist, he was determined to seek out whatever treatment would help him remain active and healthy for as long as possible. As a result, during the last 20 years of his life, Alan, through the Howard Foundation, was able to lead research into the role of macular carotenoids on vision and memory. For this, he established the Howard Chair in Human Nutrition at what is now the South East Technological University, SETU, in Waterford, Ireland, and established the BON, that's the Brain and Ocular Nutrition Network of Scientists. At the age of 90, he received an honorary fellowship from what is now SETU in recognition of his work in this field. Alan died 2 years ago at the age of 91 from prostate cancer. It is therefore very fitting that the trustees of the Howard Foundation have chosen to mark our 40th anniversary by supporting tonight's lecture by Professor Mark Emberton. We hope it will raise awareness and educate both public and professionals on such a significant topic for men's health. We welcome the opportunity to highlight the valuable work of organisations such as Prostate Cancer UK. We are grateful to the Royal Society of Medicine for hosting this event for people to attend both live and online.
Well, thank you, John, and thank you, Julie. I'm just going to read this out because not everybody. I know we've got lots of eminent urologists in the audience. I can see them from here, two in particular, sitting in the middle there. And they'll know all about Mark, but not everybody in the audience will. Mark is an exceptional urologist. He's a Professor of Intervention Oncology within the Division of Surgery. He's also Dean of the Faculty of Medical Science at University College London. Clinically active, he holds the position of Honorary Consultant Urologist at University College London, and he's a specialist in prostate cancer. His academic work is focused on developing novel diagnostic strategies, you'll be hearing about those, and new therapies, very important for men with prostate cancer. His research has resulted in the transformation of both the diagnostic and therapeutic pathways, and these have been incorporated into international guidelines. He's published over 500 peer-reviewed papers, holds a large grant portfolio, and lectures widely around the world, and holds international honorary professorships. He's the founding pioneer of the charity Prostate Cancer UK. You'll be hearing more about that after Mark's talk. Mark, it's a pleasure and an honour to have you at the Royal Society of Medicine. Over to you.
Thank you very much, Roger. Well, it's a great honour to be here and to celebrate Alan. And one of the great privileges was actually to learn a bit more about him. And clearly he was a true polymath. But the bit that really caught me was his multidisciplinarity, the way that he could work across professional disciplines. He could work with individuals that had skills that were different to his own, atherosclerosis, macular degeneration, obesity, the dietary aspects that we've just heard about. And he started new research units. And what he wanted from those research units was different with people with different expertise working together to solve key problems. And actually, that's really important for this story today. This story isn't about me. Roger's quite wrong. This is a lot of people working together to solve problems. It's been a privilege to have been part of it. And what I'm going to do today is tell you this story. But it's very humbling, because I was registrar to about half the people in this room. I owe those individuals a lot because they guided me. They were my mentors, my teachers, guided me along the pathway when I was erring. So I'm extremely, extremely grateful to all the teachers that I had the benefit from. That includes our chairman tonight, Roger. So thank you very much. So what are we going to do today? We're going to go from this slide, and the date on which this MRI was taken was the 14th of May, 1998. The details of the MRI don't matter yet. I will show you around the prostate a bit later on. This is a pretty blurry picture. It's a very, very early MRI. But it was the first time we saw, and I remember the day where we huddled around this image, and it was done by Dr. Claire Allen, who I've had the privilege of working with, multidisciplinarity. She's a radiologist that works at UCLH. And we thought we'd do a sequence that they were doing in brain that had never really been done before in the prostate. And this was injecting contrast. And we just treated this prostate with a new experimental technique, and we wanted to see whether we were making any difference to the tissue, to the prostate. And the round circles that you can see, in fact, there's quite a lot of light on here, you can just about make out 4 little round circles, is the dead tissue that surrounded the laser fibers that we'd put into the prostate. Again, the details don't matter, but this was the first time in history that I think anybody had ever seen changes within the prostate that had resulted from attempt to treat the prostate. And we could only do that because MRI was just about ready and up for the task. And that was when we started thinking about the possibilities and the future. Now, there's a big difference between 1998 and the date at the bottom, and that's because Caroline Moore, who was the first author on this paper, decided to have 2, possibly 3 children during that time, and so we were very late in getting this out to the public domain. She's now a professor working in our unit. So that was the moment. That was the first moment of kind of wonder and a sense of what might just be possible. And then I'm going to compress 10, 15 years into 15 minutes. And this, Dr. Mark Porter, who I'm sure many of you read, Radio 4, Times, earlier this year said, and this was on the basis of an article, 15-year follow-up of some work that we produce, that if I needed prostate cancer treatment, I would want HIFU. Now, HIFU is not the important bit here. The important bit here is that the treatment that he wanted, were he to get prostate cancer, was a treatment based on imaging, based on that original MRI that I've just shown you. And obviously, a lot of things happened between those 2 slides. But that is essentially the story that we're going to tell tonight. But before we do that, just a bit of background. So the prostate is nothing new. It's been around for quite a while and was first described in 300 BC. And it just takes a little while to get your head around this image, but this is obviously a cadaver. Some of you will recognize this organ, the penis. In the middle is the urethra, so the water passage, and that's the thing really to follow. And it goes right up into the pelvis, into the prostate, and into the bladder. And you can see the rectum behind, which was, until very recently, until imaging really, the only way we had to really feel what the prostate contained or to ascertain its nature. There was no other way to access it other than by putting a finger into the rectum. But as some of you may be able to see, you could only access a really relatively small amount of the prostate. And we were reliant on that approach for a long, long time. I mean, prostate cancer is described as a modern disease. It's more common with westernization. So it has low prevalence in Southeast Asia, South Asia. If those individuals move to America, to Europe, the prevalence of prostate cancer increases. It increases with age. There are certain ethnic cultural groups that are more at risk than others. And it's said to increase the further you go from the equator. So there's quite a lot we know about the disease. But it's not that new. And here's an MRI again. There's a theme to this talk of a mummy. So this is an ancient showing that obviously, in those days you died relatively young. But even in this individual, there was evidence of prostate cancer in the skeleton of this mummy that was found in ancient Egypt. And what some of you will also know about prostate cancer is that it's been a hugely controversial area. The controversy has died down a little bit now. It was much, much greater 10 to 15 years ago because people were worried that we were diagnosing the wrong cancer, people were getting treated unnecessarily, we were missing cancers, etc., etc. And it's really the problems that are buried in these headlines that we wanted to mitigate through the health technology development that we could do through imaging. And what were these problems due to? Well, one of the problems was that because we couldn't see the cancer, the only way that we could treat the cancer was to remove it in its entirety. If we found that an individual had prostate cancer, there were really 2 options for that individual. One is to remove the prostate, and that's an operation invented by the man that you can see here, Hugh Hampton Young, who was at Johns Hopkins. We celebrated the 100th birthday of radical prostatectomy about a decade ago, and he was the inventor. And that was really your only option. You either had no treatment, what we used to call watchful waiting, or you had surgical removal, or you had radiotherapy. And therefore, the treatments that were on offer to patients were really at the extremes of care. And that relates to some of the harms that you saw in the headlines that you've just seen. We'll talk a bit more about that in a minute. The other issue is that the techniques that we had, in the absence of being able to see the cancer, and just it's difficult to underestimate just how handicapped we were historically. We were used to it because it's all we had, but every other cancer was identified because of a CT scan or an X-ray, and that told you where the cancer was, and then everything started from that. We didn't have that in prostate, and so we had maybe a hint that the individual was at risk, perhaps due to a high PSA, and what we did was throw needles into the prostate in a random manner, as you can see here, without knowledge of the target that you were going after. And in this case, we caught a tiny bit of the cancer, and this individual was told that he had low-risk prostate cancer, when in fact there was much higher-risk prostate cancer within his prostate. He was misclassified. He might have been advised to have the wrong treatment. He might have been undertreated. Here is the same individual on a different day, and the needles just fell short. And you can see that this individual was told he was all clear, when in fact he wasn't. And we didn't really know the degree to which we were making these errors, because this was the only tool we had, and we knew it was fairly unreliable. The other issue, and this is a graph from Memorial Sloan Kettering, this relates to harms now, is that despite all the advances, robotic surgery, drugs that help men get erections back, better health, better cardiac status in the patients that we're treating, if you look back over the last decade, there's been no improvement in the likelihood of a man getting his erections back after surgery at a center of excellence in New York called Memorial Sloan Kettering. And that rate of getting your erections back after surgery is 20% at 1 year and 30% at 2 years in a center of excellence evaluated by somebody who's expert in this area. And that makes you pause. So despite all those advances, the men are still having to suffer significant quality of life detriment. And I suppose the other thing that was going on is that our understanding of prostate cancer over the last 10 to 20 years has really changed dramatically. We used to believe, and when I was working for Roger at St. George's, that any cancer that we found had to be treated. And that was a very realistic proposition. And if you had cancer and you were fit enough for treatment, you would undergo surgery or radiotherapy. If you weren't fit enough, you'd have no treatment, and eventually we would treat you with hormonal treatment or by removing the testes. We now know a lot more about the drivers of cancer, the genetics of cancer, but we're still not able to predict who really needs treatment and whose treatment can indeed be deferred. So those are the kind of problems behind the headlines that you've just seen. So what are the 3 areas of unmet need that we were seeking to resolve? Well, I think the first and most obvious was to see the cancer that we were contemplating, talking about, thinking about treatment. If we couldn't see it, you can see already that the outcomes were likely to be compromised. The second one is treating cancer without the side effects of incontinence and sexual dysfunction, the 2 main side effects that men who have surgery put themselves at risk. And then defining the attributes of the cancer that benefit from treatment. So in other words, historically, until very recently, prostate cancer risk was based on PSA, what you felt at the end of your finger, and the Gleason grade. So in other words, the aggressivity of the prostate cancer. These days, we can analyze the urine, we can analyze the blood, we can do genetic tests on the cancer itself, on the background prostate. There's a huge amount of information that we might want to use in order to risk stratify the patient. In other words, in order to tell the patient what his true risk is, and therefore tailor the treatment to that individual. So let's start with the first. So this is about trying to see the cancer. So this has been a human quest for as long as man has been around. We've always wanted to render the invisible visible. And here you can see 3 examples of use of technology, some more sophisticated than others, in allowing individuals and groups of individuals to see things that were hitherto beyond vision. Now, most technologies that allow us to do that help a little bit. Binoculars gave you a tiny bit of lead time if you were looking for enemy fighters, and probably not enough time to make any real difference. Radar, however, gave you sufficient lead time to get your own airplanes positioned where you want to, with the sun behind them, to surprise the enemy on attack. So not every technology results in a significant advance, only some do. And I'm going to talk to you about a technology that I think has transformed the way we think and understand, and indeed in the future will change the way that we manage prostate cancer. These are the first images of a prostate using MRI, published in the British Journal of Urology back in 1982. This is a very recent history. This has all happened rather quickly, and it's been difficult for some to get used to this very, very rapidly changing landscape. I don't think even our chairman could spot the prostate in these images. I mean, on some you can probably guess because you can spot where the rectum is, and if you point in front of it, you'll be right. But actually, these images, while of historical importance, were not that helpful. So that was 1982. If we go to 2005, dramatic improvement in what we can see. And I think here's the opportunity, I think, to just make you all radiologists for the evening. So this is Radiology 101. And so the prostate here in outline is here. The patient is lying on his back, head in, feet out. So we're salami slicing through the pelvis. This is the left-hand side of the individual. This is the right-hand side of the individual. The rectum sits just behind, and again, a finger here could only really feel a tiny proportion of the prostate. So most of the prostate is beyond the limit of the finger, which was, remember, was our principal diagnostic tool until relatively recently. The prostate is relatively symmetrical. What's interesting and unique about the prostate is that every man in this audience will have a prostate that is entirely different and recognizable as such from the man sitting next to him. It's like a fingerprint or like an iris. The prostate is unique to the individual. Our radiologists can tell who the patient is by looking at the prostate. They don't need to look at the hospital number or the name on the MRI. There are two important bits to the prostate. One is the bit that you were born with, which is this brighter bit. I'm going to show you some better images than this, but this is a story about technology development. And the bright bit of the prostate you can see around here. So that's the old bit of the prostate. That's the bit that's been around for longer than the new bit of the prostate. The new bit of the prostate is the bit that sits around the urethra or water pipe. The water pipe is usually around here, and there is growth, benign growth usually, that takes place after puberty, probably peaks when you're 50s and 60s and 70s, and we call that benign prostatic hyperplasia. So that's the benign growth of the prostate that all men get. You can get cancer in this new growth, but it's much less likely because the tissue hasn't been around long enough, and the chances of sequential genetic mutations are less. So this is the area where men tend to get prostate cancer. We used to think they only got it in the posterior part of the prostate, but that's because we couldn't reach to the front part of the prostate. This individual has a prostate cancer, and I'm sure most of you have spotted it, and it sits just there. It's sitting there at 9 o'clock, and on this sequence it looks dark against the less dark background, and you can see there's no such lesion on the other side. And so back in 2005, you could say with virtual certainty that this individual had a prostate cancer measuring about 0.5 cc's, which is about the size of a pea or a broad bean, sitting in what we call the right anterior horn. And therefore you could start to plan your treatment or your diagnostic process around that. Let's move forward a little bit. And again, you can see this extraordinary transformation in technology. This is a British invention. MRI was invented in the UK, but obviously developed and commercialized by non-UK companies, Siemens, Philips, and GE to a great extent. And this is exquisite detail. You can see the ductal architecture of the prostate. The prostate is there to make semen, to protect the sperm. The semen then liquefies and releases the sperm into the cervix. And all these are tiny little ducts making the semen. And this is the organized chaos. This is a large prostate, and this man has had fairly dramatic growth of the new tissue around his urethra. In fact, his urethra has been so squished you can barely see it at all. This prostate measures about 80 or 90 cc's. Hip joints are about 50 cc's, so this is about twice the volume of that. So we're talking about the size of a kind of small tangerine or something like that. So this is a very large prostate. Now, if we take a image of similar quality, and this is one of kind of current contemporary quality that has a cancer within it. This cancer is in a rather unusual place. It's in the middle of the prostate, and you can see if you didn't know where that was, you wouldn't know where to put your needles. And in fact, that happened when he was diagnosed. He was told he had low-risk prostate cancer. He had 2 millimeters of the so-called pussycat, what we call Gleason 3+3. But nobody thought to put a needle in the midline. We weren't taught to do that. The needles went to the left and then to the right, because that's where we thought where cancer resided. When he had a biopsy directed to the abnormality, he had disease that was of higher grade, of greater significance, and was worthy of treatment. And he ended up having Gleason 3+4 with a maximum cancer core length of 8 millimeters versus the 2 millimeters. Same cancer, same prostate, same individual, just a different approach to it. And the other thing we can see from here is the shape of the cancer. It's next to the urethra. The urethra sits just in front of it there. That might be important in terms of what we do. The cancer is unusually shaped. It's shaped like a triangle. It's invading the capsule, the lining of the prostate. It's very close to the rectum, possibly invading the fat microscopically that sits between the rectum and the prostate. So it's giving us a huge amount of detail that previously we just didn't have access to, that we can use for treatment planning. So you can see the benefits, and obviously there were a lot of people working on MRI and trying to prove its value over time, but it wasn't really until this paper that the world kind of stopped and paused. This wasn't the only study that was published at the time, but this was a study that was sufficiently large, was multi-centre, funded by a UK charitable organisation and published in a major journal. So it made people look at it. And what we did was to compare MRI to the standard of care, which is the random biopsy that I've demonstrated earlier, to see which was better at detecting clinically significant cancer. But in order to do that, we had to subject the men to what we call a reference test. So in other words, a test that can adjudicate between the two approaches. One is imaging and one is biopsy. How can you compare the outcome? So the men that were recruited to this study agreed to have a sampling of the prostate at 5 millimeter intervals. So this is like playing battleships with a prostate. So you're interrogating the prostate every 5 millimeters. This was a major undertaking, and the 563 men that consented to the study have done humanity an extraordinary service. It's the altruism of these individuals who basically said, yes, I'll allow you to do a very, very detailed prostate biopsy so we can find out which is better, is constantly humbling. And we still see these patients today. And this study will never be repeated because men will not subject themselves again to such interrogation. But this study showed that the sensitivity, so in other words, the ability of a test to detect cancer when cancer is really there, went from 48%, which is the old-fashioned biopsy, to 93%. So this is a doubling of the accuracy of diagnosis. So MRI versus trust biopsy. Normally when we do studies, we look for a 10% improvement. We power studies to detect 10% betterment. This was 100% improvement in the diagnostic accuracy of a test. But although the results were dramatic, it didn't have a huge effect because the study was a slightly unusual one. The reference test that we used was a little bit kind of unorthodox, and it was difficult to get your head round. But despite demonstrating that MRI-based strategy was the most cost-effective, it didn't really change practice. And this is a kind of interesting bit of health technology development. What is it that will make doctors change their practice? So NICE, as you know, the agency that makes recommendations on practice, didn't shift because of the PROMISE study. Obviously, the data was important, but not sufficient to change practice and to say that every man should have an MRI. Now, just remember the dates of this. So these were published in 2018, alongside, and it's rare that anybody has any original idea, there's often a lot of people addressing the idea at the same time. These are all randomized studies. So these are when you, on the toss of a coin, you allocate an investigation, in this case, a diagnostic investigation, randomly to a group of men, and then the other group, the men that are randomized to the control, get something else. And you can see here, these were all the ones that were in the public domain from 2011 on through that decade. Not all positive. The ones that were positive, saying that MRI was better, are in red. Ignore the one from the bottom for the time being. All the other ones were equivocal. So in other words, not sure. None were negative. None said that transrectal biopsy was better. And this is an interesting part of healthcare, is that everybody does their studies slightly differently. And you can see here that the entry criteria, so the first column, was slightly different in all the studies. So the studies go horizontally across, predominated by Italians, actually, interestingly. The Italians were very, very active in this area. The experimental arm differs across study, as does the control, the number of patients recruited, and indeed the outcome that you're after was different across the studies. I think what's important to note is that any study that had clinically significant cancer that, if left untreated, will affect your quantity or quality of life, was positive. So MRI was very, very good at identifying the disease that needed to be identified. But none of these changed practice. Why? It's difficult to know. They were all single center, so they were done in one hospital or one university, except the one at the bottom. And I think it's easy to criticize that. Oh, they could do that there, or we don't believe their results, or they're very lucky because they've got really good radiologists. There's always a critique of a single center study. And so the one at the bottom was the first multi-center attempt to address the problem in a randomized manner. And it overlapped a little bit with PROMISE. PROMISE was the earlier study I showed that was also multi-center. That was a multi-center UK study, and this was a multi-center international study. And again, ended up getting published in a very prominent journal and therefore could not be ignored. And this study was led by a trainee who's currently in Melbourne and coming back to the UK in March, and is going to be an incredible force for good for developing the next story in terms of prostate cancer diagnosis and treatment. So really international panel. So what did this study show? Here, men were essentially randomized. So just on probability, they were allocated to a standard of care approach. So they got the random biopsy versus an MRI-based approach. And some of the men that got the MRI didn't get a biopsy. What did we show? That fewer significant cancers were missed, so fewer bad misses, fewer insignificant cancers diagnosed. So in other words, we didn't tell people they had disease that they didn't really need to know about. Fewer men biopsied. Why? If you had an MRI, there was a 25% chance that you would be told you wouldn't need a biopsy. Fewer needle deployments. So instead of random biopsies, we targeted the biopsies. 4 for MRI versus 12. Better pathology, because you're hitting the cancer several times rather than glancing on it. Less harm, because you're putting fewer needles into the prostate, and less cost. And that was the clincher. That landed. Some of you in the audience will remember that day, and it changed the world. And very, very soon, NICE quickly, and in April of 2019, changed their view on the diagnosis of prostate cancer. And they said MRI should be offered as the first-line investigation for people with suspected clinically localized prostate cancer and report the results in a certain way. Wow. So you can imagine if you didn't have an MRI in your hospital for prostate cancer, or your MRIs were full, NICE were now saying all men going for prostate biopsy, so that this will be 1 million men a year in Europe alone, probably about 4.5 million globally every year. Offer MRI influenced biopsies, rather odd turn of phrase, but you use the imaging to guide your biopsies to the area of interest, rather than just spraying them around anywhere in the prostate. And rather heretically for many people, in those men who had a normal MRI, you may not need to biopsy at all. And this would result in 250,000, maybe more, men in Europe being able to forego or avoid a biopsy that was essentially unnecessary. And so that landed in April 2019, and the world changed the result now. I think one still sees patients who don't have the benefit of an MRI before biopsy, but they're getting increasingly rare. Very, very few in the UK. UK led this, the research was done here, and the policy changes happened here more quickly than in any other country. Interestingly, the United States, this is an interesting aspect of health technology diffusion, because they were in competition with radiologists, they were much more reluctant to accept MRI within their pathway because they didn't want to hand over the care of the patient to a colleague from a different specialty. And so here, back to collaboration, because we all work together in teams and in groups, there was no problem at all in sending a patient for an MRI. In fact, we would discuss it in groups and learn from each other in groups. So that's the development of imaging. And of course, that allowed us to start to imagine that we might treat prostate cancer in a different way, move away perhaps from the whole prostate and focus on the cancer itself. Because until then, as you now know, there were two extremes of care. Whole gland treatment with all the side effects that entails versus active surveillance or watchful waiting. In other words, monitoring the prostate very closely. And the thing that we conceived of, we called focal therapy, tissue-preserving therapies, was in some way trying to treat less of the prostate, trying not to treat the bits of the prostate that didn't need treating. And this is akin to a lumpectomy for breast cancer. The alternative would be, the radical prostatectomy alternative would be bilateral mastectomy, where you would remove all the breast tissue, which you do in some genetic high-risk cases. And this is the story of focal therapy, in other words, trying to treat bits of prostate rather than all the prostate over a kind of 15 years. And it starts up here. Oops, I'm sorry. It starts up here. We were cautious. You have to be cautious when doing research. You have to be safety first. And we insisted that men had prostate cancer on one side of the prostate, and we could, on most days, tell our left from our right, and we would treat the side of the prostate that harbored the cancer. And so this was an anatomical treatment. Once that was published, and I'll show you data from that, and MRI slowly improved, we started getting more sophisticated about defining the kind of treatment that we were going to do. So in other words, using the cancer as the defining characteristic of the treatment, so that every treatment, instead of being the same for everybody, left or right, would be individualized. So everybody would get a completely different treatment based on their own cancer. In some studies, we treated more than one cancer. In some studies, we treated above a certain level of cancer. And eventually, we're down here now, where we're thinking about treating the big cancer and then possibly treating the prostate to stop the smaller cancers from developing in the future. And this is the area of great experimentation right now. And what do we show? Well, if you save a bit of tissue, men are continent, 100%, and men keep their erections, 95%. And in this study, 95% of the men were free of disease. The 84% here are the proportion of men that were continent, potent, and free of disease at the end of this very small, very short-lived study. But nevertheless, was a very, very strong signal to allow us to develop further studies in the future, and was transformative in starting a whole new set of treatment options for patients. And some of the people in the audience today will have benefited from that. Today, what we do is we import the information from the MRI through a process called image fusion. This individual has two cancers. This is an ultrasound we're looking at now. So there's a probe in the back passage. The prostate is sitting here. You can't see the right-hand side of the prostate. There's a cancer in what we call the left anterior horn and a cancer in the left peripheral zone, so the red and the yellow. And we import that information onto the ultrasound and then treat on the ultrasound in live, watching the prostate constantly, making small adjustments. Now, this story wasn't easy. It wasn't easy to develop MRI. It wasn't easy to develop these new treatments. Not everybody liked it very much. It was kind of hard hat territory. But we were very fortunate with a lot of early supporters and donations, and some very small grants allowed us to get started to develop the proof of concept. And some of the supporters in the room tonight, and we're eternally grateful to you for those early gifts and that belief in the science to allow us to get the data to convince people like the MRC, who once they saw data, were very pleased to be part of a story. So this is the Medical Research Council that fund big projects, but they're risk averse, and they won't fund projects unless there's some preliminary data. And the role of charities, and we'll hear more about this in a minute, in generating convincing, compelling preliminary data is really, really key to then going to the big guns like the MRC and the Wellcome to get the multi-million-dollar grants. So, so this is just to show you that it wasn't all plain sailing. This is Patrick Walsh. I think during this time, it's fair to say he was probably the world's most eminent urologist, but he didn't like this at all. So this is to me that he was writing. It's disappointing that a Lancet journal would permit the authors to conclude that these patients were actually free of disease and for the authors to fool the public into believing it. So, so this is the kind of space we lived in. So I'll just take you through a case now, and then begin to conclude. So this is the modern era now. We couldn't turn the lights down a bit, stage lights down a touch. I don't know if that anybody's listening. Yeah. So I'm just going to show you a sequence, and this would be a patient perhaps presenting this week to a urology department in the UK. PSA is high, you do an MRI, and you can see an abnormality in the front part of the prostate. Most of you can see that. Looks like a rugby ball on its side, and you can see it there sitting in the front part of the prostate. These didn't exist before imaging. We told these men that they were all clear. We do numerous sequences these days. This is the blood supply to the prostate, showing cancers develop a new blood supply to feed their growth. We can exploit that as part of the diagnosis. The cells are very tightly packed, so water can't move or moves less well within the cancer. And we can assess that using the diffusion sequence. So there's less avidity of the water movement. And we can see that just about there. You might just be able to make it out on this very faint image. This individual would probably have targeted biopsies to the abnormality. In this individual, they were positive. All the other biopsies were negative. We wouldn't probably biopsy the normal prostate these days. And this individual had a treatment directed to his cancer, which took place as a day case procedure. It took about 40 minutes to do. And 4 needles were placed around his tumor, and they were between 7 and 19 millimeters apart. 4 needles using high voltage electricity allows you to treat across 6 needle pairs. So you've got the sides and then, of course, the 2 diagonals. And this is what results. So if you do the MRI a week later, you can see that the cancer is gone. All you've got is an area that hasn't got a blood supply because you've killed all the cells within it, and you can see that area just there. If you do an MRI 6 months later, the PSAs come down from 6.6 to 1.7. It's almost impossible to tell that he's been treated. You'd have to be a really good radiologist to spot that. And you see absence of disease on the other sequences. But the really important point is this. So this is an MRI, but with the patient standing up. We haven't seen an image like this yet. So this is a cut through the body. And let me orientate you. So the bladder is here, so it's above the prostate. And we can see that by treating just the cancer, we've preserved the urethra, which is the arrow is on now. The man will be continent. You've preserved the bladder neck. The man will have normal antegrade ejaculation. Non-ejaculation or absence of ejaculation is a consequence of many prostate cancer treatments. And that the nerves that drive erections, what we call the neurovascular bundles, are indeed preserved. They're well perfused. Anything you see here on white has got a blood supply. And actually, we've shown that from the various trials that we're doing, although this is erectile function now, although it dips for a month or 2 afterwards because of the injury and the impact, men can expect with a 95% probability to keep their erections sufficient for penetration after one of these treatments. And you can see that return of function happening over 3, 6, 9, and 12 months on these two graphs. So back to Mark Porter. So this is why he chose, well, why he would choose this type of treatment if he had prostate cancer. And he was weighing up the efficacy. He was referring to a 15-year study in which there was an 85% of being disease-free at 5 years for moderate-risk prostate cancer, plus a very low risk of suffering harms. And he thought that was a pretty good deal compared to the alternatives. And so that's the journey that it's taken us there. And obviously Mark Porter, a journalist but a doctor, is making a judgment based on the data that has been generated over this last year. So just coming to the end now, we're back to our friend here. What has MRI meant to the modern approach to the prostate? So you can see now, if you know where the cancer is, you can avoid these random biopsies, you can direct the needle straight into the tumor, you can get to the source of the problem, you can characterize the disease with amazing precision, you can send your tissue off for molecular analysis knowing that the cores are representative. You can do fancy tests on the genomic architecture of the tumors, as you can see here. You can also subject the MRI to metabolic analysis. These are very, very new sequences that we're just starting to do that not only tell us that cancer is present, it tell us how the cancer is metabolizing the energy, how it's using energy to proliferate and allow the cells to develop. In other words, whether pyruvate or lactate is there. So in other words, how it's exploiting sugar. And the future is looking bright, I think. We managed, despite COVID, to recruit to this study, which is called Reimagine. The purpose of this study is probably to get rid of biopsy altogether so that we can use all the elements that we know about the individual, the prostate, and the cancer that the prostate is harboring to make predictions on the nature of the cancer and the future of that cancer without having to stick a needle in. And that's been an enormous success and has attracted a huge amount of industrial collaboration. Obviously, these are universities. You can see here artificial intelligence companies, including Philips, and all these genomic companies that have tagged themselves on to this study in order to help us try and get the best predictions. You can see a lot of artificial intelligence companies. I'm not going to talk about artificial intelligence, but I'm sure it would have come up in the questions. We are using it. It is going to be a very, very important part of modern diagnostics. Here you can see a paper that shows the cancer being detected automatically without the help of an individual, and in fact, without the help of a human being. And they're getting currently about 75% accuracy on a very, very curated set of prostates. This is undoubtedly going to improve and going to mean that MRIs, we will need less radiology time, etc., in terms of reporting it. So, Chairman, ladies and gentlemen, guests, we've witnessed a pathway transformation in a common cancer within a decade. That's really, really quite rare. The benefits include more accurate diagnosis, better risk stratification, better tolerated treatment, and then really importantly, an improved understanding of prostate cancer biology. And the next decade, well, it's hard to predict the future, but I think artificial intelligence is going to be part of that. I'm predicting a biopsy-free future that hopefully I will see. And I think we'll get into an era where we'll know so much about the cancer that we can design treatments that exploit some of the features of an individual's cancer and makes it truly, truly cancer selective for that individual. So I have a lot of people to thank. This has been the work of many, many people. We've been very privileged to work at UCLH and UCL with such fantastic supporters. Another story, actually, that's really important for the UK is the merger of the small prostate cancer charities into Prostate Cancer UK, which is now a global force and a major leader in driving policy and funding around the world that you can see there. But a lot of this work was initiated, as I've said, by small charities, by individuals who helped us do the studies that we thought needed to be done at the time. So thank you very much, Roger. It's been a pleasure to spoken to you tonight.
Well, that was a fantastic exposition, wasn't it? It's absolutely brilliant and so clear. Lovely slides. Mark, we'll get Mark up on stage and we'll put to open the floor to questions in just a minute. But I just want to introduce Matthew Hobbs. Just briefly, Matthew's appointed Director of Research in June 2020, having joined Prostate Cancer UK in 2013 as Deputy Director of Research. Before that, he was Head of Research at Diabetes UK. And I like this last paragraph, Matthew, because outside of work, Matthew is a keen runner, currently chasing an elusive sub-320 marathon. That is pretty quick. Even keener purchaser of running shoes. He's a committed Evertonian, spending much of his spare time being bitter about Liverpool FC's current success, turning to American sports when English football becomes too depressing. So, Matthew from Prostate Cancer UK, you're on just for a few minutes.
So I'm going to talk to you about Everton. I'm not going to talk to you about Everton. I wanted to talk a little bit. So, first of all, congratulations to Mark on the awarded lecture, and thank you to the Howard family for putting this evening on. I want to talk to you a very small amount about Prostate Cancer UK and what we do, but actually to hopefully extend some of what Mark started to present there about where do I think we're heading next. So Prostate Cancer UK, as Mark said, formed in 2012 by the merger of two charities. One of those charities, Prostate Action, was founded and run by Roger for a long time. And actually, that was one of the charities that funded some of the early work that allowed Mark to get that big grant from MRC to do those pivotal trials in MRI. So we at Prostate Cancer UK use this as an example of our research impact. Actually, the two people at the front of the audience are the people who should actually take that credit. So, as I say, Prostate Cancer UK formed in 2012. I joined in 2013, just post-merger, and it was a really, when I look back at that, so what's that, 8-9 years ago, that was the point at which we were just pre-MRI. So actually, one of the things that Prostate Cancer UK does, I'm going to talk to you about our research funding, but one of the things we do is we run a specialist nurse helpline where men who are going through diagnosis or going through treatment for prostate cancer can phone our specialist nurses, ask them any questions they've got. And far and away, the majority of the questions that the nurses were getting in 2013 were, I've got a raised PSA, I've been sent for a biopsy, do I need it? Or, I've been sent for a PSA, I've got the biopsy results, can I trust them? And honestly, in 2013, the actual answer probably was, in a lot of cases, we don't know, we can't be sure. For exactly the reasons that Mark has pointed out there, we were sending tens, if not hundreds of thousands of men for biopsies they didn't need, that we now know they didn't need. We were telling probably thousands of men every year that they had a low-risk cancer that didn't need treating, but we couldn't be sure because we couldn't see the prostate. We didn't know if those biopsies had been accurate or not. And we were guiding men to different treatments on the basis of that lack of knowledge. And so I feel very privileged that I joined Prostate Cancer UK and joined the prostate cancer world just at the point that Mark was starting to finish those clinical trials that he told you about. And Mark has presented that very humbly, but he did allude to the fact that this is global impact from clinical research. You know, it took those two trials, both of those trials designed by Mark, both of those trials funded by his persistence in getting the funding to do them, and both of those trials delivered by the teams led by Mark and mentored by Mark. And it has changed practice everywhere across the world in the space of about 5 years since they were developed. And I think Mark has underplayed his impact there, and so I just wanted to make it clear that is huge impact, making a massive difference for men with prostate cancer because the diagnosis is accurate, and possibly an even bigger impact for men without prostate cancer who we no longer need to biopsy, and so has spared that unpleasant procedure. So that's kind of where we are right now. The other thing that Prostate Cancer UK does is that we fund research. So we fund pre-COVID, we were funding about £7 million of biomedical and clinical research in prostate cancer every year. We are aiming to grow that to £10 million a year, and we've got some exciting plans to grow that even further that may come up in the questions, I suspect. But I think, and so we've got a very broad research funding strategy. We will fund research that goes right from the basic biology of the disease. So what can we find out about prostates that have been removed surgically? What can we find out about the biology of prostate cancer? Through to diagnosis, right through improving treatments for localized disease, right to the very end stage disease and improving treatments for advanced metastatic prostate cancer. And I'm not really allowed to have favourite children. But if I had a favourite child in our research strategy, I think it would be the improvements we've made and the potential for further improvements in diagnosis research. So we've seen the huge leaps that we've made. I think imaging in prostate cancer, this is only the start of the story. It's a huge step forward. But actually, one of the really exciting things is that we couldn't see anything before. And now we can see pretty accurately the prostate and the cancers. But the technology and the potential to develop that technology further to do even more benefit, even more impact, are huge. So I think there are 4 key areas that I think are coming next. So I get a bit of insight here because we're funding some of this work already. I should say that almost all of the work I'm going to talk about that's coming next is either led by Mark or led by people that Mark has trained, who you saw on the slides. It's very rare that we get any sort of application on diagnosis of prostate cancer that doesn't involve somebody that Mark has brought into this field and is now making impact on his behalf, I guess. But what are the 4 areas? Where do I think we're heading in future? So I think one of the things that Mark alluded to is this is a great technology, but we are a bit short of MRI scanners in the UK, and we are definitely short of radiologists in the UK. And so one of the really key areas for research going forward, and we're funding work in this space, actually led by Viru, who was the fellow who delivered the precision trial, is can we keep the accuracy but make the scans easier to do and cheaper to deliver? And it looks like actually there are ways that we can do that. We need the research to prove that we can. We're now in the place with that where we were perhaps pre-promise, where there are some believers and there are some non-believers, and we need to convince the non-believers by delivering those clinical trials that will prove that we can do that. That will improve access and quality of MRI across the UK primarily, which is my interest, but globally as well. I think sort of contrary to that, I guess, Mark alluded to this as well, can we do more with MRI? Can we actually use different ways of doing MRI scans, different techniques, different combinations of scans to actually see more? So rather than just seeing the outline of the cancer, can we understand what the cancer's doing, how it's metabolizing, how aggressive it is? And we've already seen some good evidence from small trials that actually there are techniques that will allow us to say not only that there's a cancer there, but that it's an aggressive one. So that move to maybe not needing to biopsy at all. The third area, I think, and again, Mark mentioned this, so I'll just talk about it very briefly, is artificial intelligence and machine learning. There is a wealth of data produced by these trials and by these techniques and by this imaging that we now do on pretty much all men who are diagnosed with prostate cancer. I agree with Mark that the AI companies and the academics who are working on AI are right at the start of this journey, and we're already seeing rapid progress. I think we can look at breast cancer, where that's starting to come into screening programs, the sort of automated reading of mammographies, to see where the future's going. Again, it's an area that we need to fund research, deliver the research, and get the results before we get there, but it's definitely where we're heading. And then the fourth area I'm going to mention very briefly, and I'm going to mention it mainly because it always comes up in questions when we do one of these panels, and it always comes up in panels because it is the most important question in prostate cancer. So despite these advances, and despite all the other advances that we've made, every year in the UK, we still see over 9,000 men diagnosed with prostate cancer only at the point that it's already spread around their body. So fully metastatic, incurable prostate cancer, diagnosed too late, diagnosed so late that those men have got no chance of us curing that disease. The only way we're going to start to reduce that number, diagnose more of those men when their prostate is still contained, where they can benefit from some of those treatments that Mark talked about, is to get to a national screening program for prostate cancer. And the only way we'll get to a national screening program for prostate cancer is to fund the research that shows government, and also the screening committee especially in the UK, that we've got a pathway or multiple pathways that are accurate, that do less harm than we used to do when we diagnosed prostate cancer, and that are cost effective. Now, this is something that we are very actively trying to fund. We've got a proposal in hand. Mark is on the leadership team of that clinical trial that's been designed that we're trying to fund. I'm confident that we will fund it. It will be, by an order of magnitude, the biggest grant that Prostate Cancer UK has ever given, but it is also, by an order of magnitude, the most important thing that we can do for men. And I think MRI is going to play a huge role in that trial, and I'm confident that trial will be positive, and it will eventually play a huge role in screening for prostate cancer. So I'm going to stop there. I guess I'm going to stretch Mark's analogy a little bit. I would say that Mark's work up to now has opened our eyes. We can now see things where we could see nothing previously. I think the next 10 years and beyond, through Mark's work again and through the work of people that Mark has trained and mentored, we'll start to see more and more, and we'll see things that we didn't even believe were there to start with. And so I will stop talking, say thanks to the organisers, thanks to Roger, and thanks to Mark, and congratulations.
Whilst Mark's sitting down, it reminds me that when I first started doing urology, the only way we could make a diagnosis of prostate cancer was putting a finger in the rectum and palpating the prostate. And I had one patient who said, "Doctor, would you mind using 2 fingers to do that?" And I thought, why on earth would you want 2 fingers to do that? He said, "Well, I'd like a second opinion, please." So some questions from the audience. Are there any microphones around? If not, you just have to speak rather loudly. Sir, the man with whose telephone went off halfway through.
Very sorry. Thank you for such a masterful summary. It shows real mastery of your subject, not only about the work you've done, but how you put it in such a simple, easy to understand way. One thing you slightly avoided talking about, because obviously it's a limited time you had, was the parallel work on drug treatments. Of course, the first Nobel Prize given, yours might be the second, but the first Nobel Prize for this area was Huggins's work, of course, on estrogens, and then it was the LHRH inhibitors, and then not much happened for about 35 years. And in the last 5 or 6, 7 years, there have been all this group of biomarker-related drugs, mainly for metastatic and more widespread LTRKs and lots of interesting mechanisms. Can you foresee a time where your work with the careful diagnosis, the accuracy, the anatomical diagnosis is going to meet up with this biomarker-targeted treatment, and you can almost, you have the radiologists and the oncologists and the poor urological surgeons aren't having to poke around anymore much in the prostate, and it's just melting away with these targeted treatments.
I'm going to stop you there because we need nice short questions.
Yes.
I summarise that because the people online may not have heard that without the mic. We've now got the mic. I think prevention of prostate cancer, is that a possibility? I think that's kind of what the question was asking.
Yeah, we haven't been very successful at doing that yet. And I mean, there have been many strategies to prevent precancerous lesions becoming cancerous. They weren't that effective. I think now with the tools we can monitor a very small lesion, which is what you're alluding to, we can start to kind of revisit that again, I think. And we're open to that, using lifestyle changes, drugs, maybe nutritional supplements, and indeed drug. There has been one study that has used one of the new hormonal treatments for very, very early small cancers to see if such a shock would just get rid of a cancer completely. I think there's the answer is probably that you can, but the side effects currently are probably too great to make that a realistic treatment. But you've alluded to another UK phenomenon, you know, so in other words, the growth of all these new drugs, abiraterone, and you know, that's another team from the Marsden, you know, Johan de Bono, Gert Attard, did all that early work, which produced drugs that for the first time prolong life rather than just ameliorate symptoms.
I see a question from Professor Vale there. I should say Professor Vale is CEO of King Edward VII Hospital, where Mark works. We just heard today we've got an £80,000 grant to support veteran support the veterans there. So we're happy today. Justin.
Thank you, Mark. I thought that was a fantastic lecture, and it's great the way you took the evolution from seeing prostate cancer to be able to treat it focally. But it took 3 or 4 years from the PROMISE study for people to wake up to it and other people to follow you. And if you look at focal therapy, there are only really, that I know of, 2 really big centres providing focal therapy at volume, and that's yours and Imperial in London. We get referrals from all over the country. When are the rest of the country going to get where you are on focal therapy, and what study are you going to do to get them there?
It's a really good question, and I don't know the answer. So this is about technology diffusion again. So why do some things suddenly change the world overnight? Laparoscopic cholecystectomy was one. So in other words, keyhole surgery for removing your gallbladder. Suddenly, everybody was doing it. And why do other things take forever? And I think the answer is difficult and complex. I think there are lots of reasons. Focal therapy is difficult. You have to have excellent imaging. You have to have really good biopsy strategies. You have to have lots of capacity to do follow-up. You've got to have people around you that allow you to do something new, that permissive, societal right, if you like, to do something different. And we've been very lucky. We've been allowed to do new things. And it's, Imperial and UCL are two kind of places that have allowed us to do that. I don't think the atmosphere is as tolerant in other places for doing new stuff or making changes. Now, I think if we kind of forward your question, now with the NHS under huge pressure, you'll know this. If I come to you with a proposal that involves doing new things, you're going to say, go away. You're not going to meet me with open arms because all you're worried about. Sorry?
Come back with the funding.
Well, yeah. And so there's a reluctance to try anything new when the system is under huge pressure. There's an evidential issue. We're working with NICE currently to see what kind of evidence they would require in order to make the judgments that we shared with you earlier. For treatments, it's a lot more difficult. And we've failed to recruit men to studies because men withdraw their consent. So if you randomize them to surgery versus focal treatment, 25% of the men randomized to surgery will say, no thanks. And so you can't do the study. So these are the discussions we're having. So I haven't answered you very well, but we are working on it.
Anybody, hands up again? Okay, who are we going to choose? We're going to have the front row. One of the Howard family who are sponsoring the event. Thank you.
Can you tell me what procedure you use if you can't use an MRI because the person has got heart problems and he's got a monitor?
It's a really, really good question. So there are lots of reasons why men can't have MRIs. Some men just can't. Claustrophobia. I'm quite claustrophobic. I don't like being in confined spaces. Some men can't tolerate it at all. You have to give them a general anaesthetic to do it. These days, we can do an MRI with a pacemaker. So you have to go into a weak magnet, but we've got those magnets. Not every magnet can do it, and you need a cardiac technician present. So it's a bit of a faff, but it can be done. The thing that's really stopped you having it, if you've got bits of metal, so a cochlear implant is a no-no, a bit of shrapnel or a bit of metal in the eye from metal work, or and that's obviously cannot be done. So because that metal would move and would cause an injury. So what's left? Ultrasound. Although I dissed ultrasound earlier, modern ultrasound with AI, and this is high frequency ultrasound, which they used to use to look at the hearts of mice, which beat really quickly, is showing some promise. There is at least one company that is developing quite a bit of traction. They think they can see cancer. The other thing, in fact, there was a report today, actually, I had to review a paper that showed that PSMA PET scan, so a PET scan where you put a tracer in and it goes to the prostate bits of you, is almost as good as MRI at telling you where the cancer is. So if somebody tells you you can't have an MRI, there are other options available to you, and I think they're largely ultrasound and or PET, PSMA PET.
Any questions for Tom about Prostate Cancer UK? Sir?
Yeah.
Can you reach, pass that back, Justin.
Thank you. Tom, as Mark pointed out in his great presentation, there was a time when if you wanted a treatment, it was radical prostatectomy or nothing. And of course, active surveillance is a cost-effective and clinically effective management strategy for a lot of patients. Nonetheless, do you feel that men, particularly those with low or favorable intermediate risk localized cancer, are always getting offered all of the potential treatments that are in that big space between active surveillance and radical prostatectomy, that they should be being offered?
I think the answer to that is no, they're not. I think we've heard about the fact that focal therapy is available not very widely in the UK at all, albeit that people can be referred into UCL or Imperial. And I think we are also working with NICE to see what can be done about that evidence. I mean, just to add some detail to that, when NICE were first asked to look at focal therapy for prostate cancer, what I think they said was, there's not enough evidence we want. So in the absence of those trials, what we want to see is the data from men who are treated like this, and we want to see the long-term follow-up. That data's now there. They asked for the data. They should really just be looking at that data. So I think there is a real problem with focal therapy and availability. I honestly, as a research funder, I'm not sure it's a research question anymore. I don't know if I should be funding research into focal therapy, because I think the evidence is probably there and it just needs looking at by the right people. But what I think is certainly a problem is men, how we guide men to the right treatment for them. I'm going to steal a line that I heard Mark say at a conference years and years ago, which has really stuck with me, which was, we should be offering men the lowest burden treatment that cures them. So the minimum amount of treatment to get a cure. And for some men, that is active surveillance. They don't need treating. For some men, it's focal therapy. For some men, it is radical therapy. And actually, for some men, to come back to the question earlier, it might be a full gland treatment and one of those drugs, that actually their cancer might be so aggressive that we want to do more than just treat their prostate. But I think we need to get more accurate about being completely sure, or at least we need to convey that confidence that we've got to the men, because actually a lot of the men we see on active surveillance don't stay on active surveillance for very long, because the psychological pressure, the burden of knowing there's a cancer there is still too much, and they end up converting to radical therapy and suffering the side effects that comes with.
I'm so glad you've said that, because speaking as someone who just a couple of months ago began 2 studies on prostate cancer treatment, I wasn't expecting within a couple of weeks a very close relative would then have a high PSA picked up on a routine blood test and now have a diagnosis, and who was horrified. Now, I know that obviously treatment options are very subjective.
Sure.
And what works for one person isn't going to be a choice for another, but was horrified at the thought that active surveillance might be the preferred pathway. And I'm sure that's probably true for many men.
Well, yeah, some are horrified at the thought of surgery, aren't they? It is very emotional, and it's interesting that we have a forest of hands wanting to ask questions, but we're running a bit late. But I have one last question. Sir, at the end there. Yeah.
Thank you very much for an illuminating lecture. I'm just curious whether the management of those who are unfortunate enough to be metastatic at diagnosis, has that really been transformed over the last decade, and what's the outlook for the next decade?
Maybe let's let Matt ask that one, because that's a good one for research.
I'm interested in Mark's take on that, but certainly from my point of view, I would say it has been. So when I joined Prostate Cancer Care in 2013, we had, in terms of drugs in that space, chemotherapy, so docetaxel, androgen deprivation therapy, so removing the hormones, and we were just starting to see abiraterone come into use. Since then, we've added not just new drugs, but drugs that treat the prostate cancer in a completely different way. But I think actually the big change, so the trials that have delivered those drugs have shown probably 6 months or so of survival benefit as a maximum. But you're talking about men at the very end stage of prostate cancer. I think the really, really big progress, again, has been UK-led, has been bringing those drugs and moving them earlier in the disease pathway. So still in the metastatic state, but the Stampede trial has taken those drugs and given them to men just as they're diagnosed with metastatic disease. And we're sometimes seeing extra years of life added, not by developing a new drug, but just by taking the ones that work and moving them earlier for the right men. I think the next stage in that is not treating all of those men as if they've got the same prostate cancer, but starting to treat them on the basis of what we know about their individual cancer. I think we'll start to see, I think we've probably doubled life expectancy for men with metastatic disease over the past 10 years. I think that will rapidly increase as we get to a more precise place. I'm interested in Mark's take as well.
Sure. And the holy grail, as you said, is a screening test that works, which Prostate Cancer UK is really working hard on. So I think, John and Judy, just stand up for a minute. I'd like a round of applause for our speakers. And a special thanks to the Howard family and their friends here in the front row, because without that, if Alan were here, I know he would have loved, maybe he is up there listening to, and probably applauding Mark and Tom as well. Thank you very much, everybody. Good evening.
Well done, Tom.